Hi, I'm Kiana Rush. This is week 5 of pharmacology tutoring for Southwest College of Naturopathic Medicine in Tempe, Arizona. And this week we are going to be covering antiarrhythmic drugs. So there's two types of cells in the heart. There's pacemaker cells, which are seen in this image, their action potential. And there are myocytes, which are seen in this image below. Both of these come from the USMLE, page 292. I really highly recommend it if you're feeling a little bit behind on the physiology of the heart. That'll really help you get these drugs down. So I would review this first. So antiarrhythmic drugs, there's 4 classes: sodium channel blockers, beta blockers, potassium channel blockers, and calcium channel blockers. So to start out with the drugs, the first one we're going to mention is propanol, and it might look familiar. I think you've seen it a couple times before. So it's a non-selective beta blocker. So it's going to shut down some of that adrenal receptor response to the heart. So we're going to get less fight or flight response. The heart's going to beat less quickly, less hard. It can be used directly following a heart attack to prevent ventricular fibrillation, thyrotoxicosis, and it will slow the metabolic symptoms for these patients with thyrotoxicosis. So, just to cover a little more here, thyrotoxicosis is caused by what? So thyrotoxicosis, you have too much T3, T4, and what happens when you have really high thyroid hormones? The metabolism is going to be kind of ramped up. You're going to get a quick heartbeat. You're going to get sweaty and just kind of be generally restless. And propanolol can be useful as an adjunct to treatment for people who have hyperthyroid symptoms. So it's not the first treatment for those patients, but it can be an additive therapy. Propanol in thyrotoxicosis. Some side effects that are well known, hopefully at this point: bronchospasm, because propanolol is non-selective, so it's also going to get the beta-2 receptors in the lungs. Even though we don't want those to be affected by the drug, it's going to cause bronchospasm, which is an unwanted side effect. Cardiac depression, AV block, and hypotension. That's probably if you take too much. All right, amiodarone. Amiodarone is a group 3 antiarrhythmic. So that means it blocks the potassium channels. It will increase the duration of the action potential. So it's making that whole action potential longer. And it increases refractory time, which is how much wait there is between the next action potential. So it's not only lengthening the action potential, it's also lengthening the time in between action potentials. So it can be used in refractory arrhythmias, which means that the patient has had ventricular tachycardia or ventricular fibrillation twice in less than 24 hours. Some side effects are actually pretty serious with amiodarone and probably good to know. They can cause deposits in the skin and cornea, optic neuritis. So I'm working my way down here. I actually like to group symptoms kind of like top down because it helps me see the patient better. So deposits in the skin and cornea affecting the eyes and the skin, optic neuritis, which is inflammation of that optic nerve, so we're still in the eyes there, thyroid dysfunction, and pulmonary fibrosis. A little mnemonic that I like to use to remember amiodarone: you're late, because it causes a longer action potential and a longer refractory period. So it's like you're telling your friend that they're late. You're late. And your friend says, am I? Oh darn. And that kind of looks like amiodarone. You're late. And nobody wants to be late. Oh darn. It happens sometimes though. That's how I remember. It's increasing that time. It's making it a lot later. Verapamil and diltiazem. These are both group 4 antiarrhythmics, so they block calcium channels. Calcium channel blocker for verapamil. It's going to slow conduction to the SA and AV nodes and prolong the PR interval. It can be used in AV nodal arrhythmias and prophylaxis for arrhythmias. Some side effects are cardiac depression, hypotension, and constipation. One side effect that's good to know for verapamil would be that it causes very bad constipation, worse than diltiazem. So very bad constipation with verapamil. And when you think about it, calcium is needed to contract smooth muscle as well. So when we're blocking calcium channels, specifically for the heart, they also affect the GI. And the intestines can't contract as well when we're taking a calcium channel blocker, and that reduced peristalsis leads to constipation. Diltiazem, also a calcium channel blocker. It slows conduction from the SA and AV nodes, and it prolongs the PR interval. It can be used to control the heart during afibrillation. So that's a little bit different here. This one's extremely useful in AFib. Side effects are similar to verapamil: cardiac depression, hypotension, and constipation. But remember, verapamil has very bad constipation, and diltiazem isn't as bad. What I like to remember for diltiazem, I don't want to die from AFib. So when you're thinking about a drug that treats atrial fibrillation, die is what diltiazem starts with, and atrial fibrillation can be really bad. It's when the atria are just both beating way too fast and not in good time with the ventricles, and it can be really dangerous for the patient. And actually, when they're beating so fast, both the atria, that turbulent flow can cause clots to form and increase the risk for stroke potential following that. All right, a few review questions. What drug increases refractory time in the heart? And the answer here is Amiodarone. And why is this useful? Because it's going to prolong the action potential, and it's going to prolong the refractory period. So we're making that signal longer, and then we're making the time between longer so the heart can't beat so fast. So we're spacing out in two ways. All right, what is this PR interval? We hear it a lot. It's actually the time from the SA node to the AV node. So it's that first part of conduction in the pacemaker potentials. And I remember that it always goes SA to AV because it kind of spells save, S-A-A-V. That's how I remember it. Why do CCBs prolong this? The PR interval is prolonged by calcium channel blockers. So they're prolonging the conduction from the SA node to the AV node. They're making that time longer, similar to how amiodarone works. They're making those action potentials longer. CCBs prolong this because no calcium will enter during phase 0 of the action potential. And I'm actually going to scroll back up here so then you can look at this one more time. So we're right here, and we're blocking these action potentials with calcium channel blockers. So diltiazem, verapamil, they're blocking these, then we can't make this action potential in the pacemaker cells, and we're not initiating anything to make the heart contract. So the heart beats a lot slower. Can be useful in a patient with an arrhythmia. Which drug is used after ventricular fibrillation and ventricular tachycardia twice in 24 hours? This is also known as a refractory arrhythmia. And the drug of choice here is Amiodarone. And what is the most severe side effect of this drug? And I would say it's going to be that pulmonary fibrosis. So those lungs of the patient taking amiodarone eventually become sclerotic and hard and have an issue not only returning oxygenated blood, but they'll have issues breathing as well. And these patients can develop something called ARDS, or adult respiratory distress syndrome. And here's a little good review question that you'll probably see multiple times. Hopefully you get this one. It's a good one to end on. What drug is useful in stage fright? And your good old non-selective beta blocker, Propanol. All right. If you guys have any questions, feel free to email me. I have these notes for you guys to access too. And if you can't get to them, email me, we'll get them to you. And hopefully pharmacology is going well. Enjoy it.